Hi everybody, welcome to Labor and Delivery Part 2 of the first internet module. So we are going to remember that we were talking a little bit about the 4Ps and we didn't get to the powers, so we're going to talk about powers, which are the uterine contractions. So there's two segments of the uterus, and the first is the upper and the other one is the lower, and the upper segment is what contracts and pushes the fetus down, which we talked about. The lower segment is less active, allowing the uterus to thin and dilate. Each contraction, however, has a resting phase in which blood flow returns to the uterus and placenta, which is reduced during the contraction. So uterine contractions are responsible again for effacement and dilation, the descent of the fetus, and there's also what's called this involuntary urge to push and voluntary bearing down. And this occurs once the cervix is fully dilated and the woman has the urge to push. It is activated by what is known as the Ferguson reflex, which is activated when the presenting part stretches the pelvic muscles and stretches the receptors, which then activates the release of oxytocin, which then stimulates contractions. So when we look at uterine contractions, we're going to start with the description. We look at frequency, duration, and intensity. So the frequency is the time from the beginning of a contraction to the beginning of another one, and it's recorded in minutes, i.e. occurring every 3 to 4 minutes. The duration is the time from the beginning of one contraction to the end of that contraction, and it's usually recorded in seconds, i.e. lasting 45 to 50 seconds. The intensity is the strength of the contraction. If it's mild, that means when you actually palpate the fundus with your fingertips, you can easily indent. There's moderate. When you palpate the fundus with your fingertips, you can slightly indent, still indent that fundus or the stomach. When it's strong, the uterine wall or that fundal part cannot be indented at all. So now we're going to look at the three phases. We have the increment phase, which is the start of the contraction, and it's the build up and it lasts the longest. Then we have the acme phase, which is the peak of the intensity, the highest point of the contraction, but it's also the shortest. And then we have the decrement, which is the decreasing or relaxation of the uterine muscle. When you think of these three things, you can think of increment, like increasing, so it's beginning and it's increasing, it gets to its peak or the acme, and then it decreases or the decrement phase. So here's a look at a contraction. Here's the increment, the peak, and the decrement. Here's your duration, beginning to the end of the contraction, and here is your frequency from the start of this contraction to the start of the next contraction. And here is the resting phase for the uterus where the blood flow returns. Again, a look at duration and frequency, and as you can see, these little blocks, and we'll look more at strips, but those are minute blocks, so that helps you to see. That's a 5-minute period of time. One thing to note is that a prolonged contraction, anything lasting greater than 90 seconds, important to remember, or too frequent, more than 5 and 10 minutes, does not give the uterine time to relax in order for blood flow to get back to the placenta, and it can result in fetal hypoxia, not enough oxygen to the baby, and also a decrease in fetal heart rate. So here's just a look. Remember, we talked about mild, moderate, and the maximum as far as, so we have mild, and then here is a very contracted uterus. Here's another look at a contraction. So again, we can also measure them from peak to peak, but important for you to know is the timing that we talked about. So when we begin to look at, okay, so now the baby, the power is pushing down, so we're looking at what's called engagement, and we really want that baby to be engaged. So remember, we're looking at the ischial spine as far as the station, which is right which is right around this area. So this baby here is engaged. It's in the pelvic outlet. This baby is what's called floating, hasn't gotten there yet, and there's a lot of complications that can occur when the baby's at this point, when the woman's in labor. And here, this one's called dipping. Baby's close, but not quite there yet. So when we talk about labor, there's the onset of labor. So there's true labor and there's false labor. And true labor is defined as the onset of regular contractions that lead to cervical effacement and dilation. Really important. You have to have those two things for it to be true labor. False labor are labor pains that don't produce any cervical changes. Hydration and sedation can also often slow down these kind of contractions for the woman because nothing's happening to her cervix, so we don't really want her to have these contractions. So once her membranes rupture, so all of a sudden she's like that little girl that we saw in the first video. She's hanging out and all of a sudden her membranes rupture. There are some tests that we use to assess rupture of membranes if she's in the hospital. So there's something called spontaneous rupture of membranes and artificial rupture of membranes. So spontaneous is when it just happens, and it could be a gush or it could be a trickle. Oftentimes, but not always, labor usually starts within 24 hours. We really want it to because prolonged rupture of membranes greater than 24 hours before delivery can lead to infection. So if you're around as the nurse and she ruptures, the first thing you need to do is to assess for fetal heart rate. So you're assessing what is the fetus doing? How well did that fetus tolerate this? Did a complication occur once those membranes ruptured? So you can look for what's called abrupt decelerations in the heart rate. So the heart rate was hanging out at 130 and now all of a sudden it's 80. When the membranes rupture, there's other things that you need to look at. You want to know what time did it happen? How much? What is the color of it? Because we want it to be almost a very pale straw-like color. If it's anything other than that, it's an indication that there could be infection. Odor, it shouldn't really smell like anything. It should not have a foul odor at all. So you're assessing for all of these things. And again, the first and foremost thing that you're assessing once those membranes ruptured, all of these are essential, but did that baby tolerate it? So what is the fetal heart rate? So there's a couple ways to do this. This is called nitrazine paper, and that is just swabbing. When it turns blue, it means that it has ruptured. If it turns yellow, it means that it is not, the membranes have not ruptured, and it's probably urine that you're seeing. There's an AmnioSure testing kit. So the last thing here I think that we're going to talk about is what's called the mechanism of labor, and there's actually 7 different things that occur. So the first thing that occurs is what is called engagement. So the baby is engaged, which we looked at. So there it is at station 0, right at the ischial spine. So we now know that the baby's engaged. The next thing that happens is what's called the descent, and it's known as the cardinal movement number 1. The fetal head enters the pelvis with the sagittal suture, sagittals aligned in the transverse diameter, so aligned this way as opposed to longitudinal. The next thing that happens is flexion. So the flexion of the fetal chin to the chest occurs as the fetus meets resistance from the soft tissue of the perineum. The next thing that happens is what's called internal rotation. So this internal rotation aligns the long axis of the fetal head with the long axis of the maternal pelvis, or the AP diameter. External rotation is the resistance from the pelvic floor that causes the presenting part, hopefully the head, to pivot under the symphinus pubis. And a lot of times this is sort of manipulated by the provider as the baby is being delivered. So then cardinal movement number 5 and 6 is restitution and external rotation. Restitution occurs when the fetal head realigns itself with the shoulders, which helps to rotate it into an oblique AP diameter. And then the last is expulsion. And the thing with these cardinal maneuvers is you need to know that they exist, because it's just important to basically see what happens. And I think we have time, so I'm going to show you this video of, I hope you'll be able to see the whole thing. It might buzz off, but you will be able to go on here and reopen it on your own if you need to. Yeah, it's not very long, so we should be good. Why are you not opening it over there? Shit. So all of this is really the cardinal maneuver, is what's going on here as the baby's born. You can see all of those rotations that occur. Okay, so that's it for part 2. So we can look forward to part 3. And remember, you can go back and watch those cardinal movements of labor or review any of this video at any time. I hope it was beneficial. And again, please let me know if you have any questions or needs.